Dear ladies and gentlemen, first of all, thank you very much for inviting me and for giving me the opportunity to present here some of our results from the Czech Republic, and I hope that you can find this IT story, let's say, at least a little bit interesting for you. It's going to be a story on building or development of our national information system for healthcare control and management. And one may ask now why to discuss something like data collection, data validation, and other IT business when we should speak about communication of evidence, when we should advocate for evidence usage and implementation. And that's the principal question of my presentation, as you can see behind me. And the question is, can effective data collection and validation and sharing be helpful or can be in aid in healthcare standardization? Do we need something which I call here clinically based evidence or real-world data processing? Do we need it when advocating for evidence use, when convincing policymakers, stakeholders to do something, when finding weak points in some implementation on evidence already published? And the answer, based on the Czech experience, is definitely yes, we need it. Because evidence-based medicine, publishing of rules, rapid recommendations, systematic reviews is just one side of a coin. We need to control it. We need to control the implementation. We need some feedback over interventions realized. We need to control compliance of patients, providers, payers, etc. And then we definitely need real-world data processing, real-world data collection. And that's why we had to develop our completely new national information system, which is just an example of IT infrastructure, which is responsible for doing it. And our story, let's say, started exactly 10 years ago in September 2014. And the initial position of us was really not favorable, because at that time we had no e-health tools really implemented in practice. We were challenged by very old-fashioned hospital information systems and many administrative data sources which did exist, but they were fractionated and they had never been joined systematically at the national level. Any idea to collect data from national perspective generated enormous administrative burden at that times. And that's why we had to fundamentally change the environment with completely new legal background for data centralization and the structure. Now I'm glad that I can announce that we managed that and we succeeded, and the structure of the system is behind me. And that's why I've got slides, because I cannot describe the structure of it by hand. So this is the structure of a really functional system. And as you can see in number 1, 2, 3, there are core elements or basic elements of e-health system. When I teach students, I call it identity space. It means National Registry of Patients, National Registry of Healthcare Providers, and of course, healthcare professionals with 100% coverage of the whole population. And this, let's say, e-health framework encapsulates the integrated information systems in the middle of the picture of the slide. And starting from the bottom, number 4 is the most important one. We call it the National Registry of Reimbursed Healthcare Services. And it centralizes all data, all records of all our health insurance companies. And we took the advantage of our health insurance tax and our healthcare systems, because this system is capable to centralize each individual hospital stay, each individual record, each individual medication at individual level since 2010. So now, currently, we have accessible for our analysis nearly 14 years of follow-up in the system, which is based on health insurance companies' data repositories. The middle part, also very important, currently standardized information systems of hospitals, but not only hospitals, also clinical information systems of GPs, primary care specialists, and they are interlinked in just one data bridge, and both layers are are interconnected, coupled, so it allows also mutual validation of data. And finally, we managed to centralize data in necessary epidemiological registries, as you can see under number 6. For example, National Cancer Registry, National Registry on Diabetes, to control population-based trends, epidemiological trends. The whole system is supported with some additional information applications, let's say, or separated systems which control, you can see it in number 7, 8, which control screening programs, prevention programs, palliative care, end-of-life care, etc. And the whole system works like an engine pumping all the data to just one central repository where we can produce some reports, open data, and some analysis that hopefully can convince anybody to do something or to focus on some weak points. I've got 10 minutes, so I cannot go to the details, so I've prepared just three examples that document the way how we communicate the outcomes and how we communicate the big data which are inside the whole information system. And again, it controls individual level of primary records, so we are capable to quantify even patient pathways or patient trajectories in the system of not only medical care but also social care. So first example, population level of reporting. I took a very up-to-date and relevant example of prostate cancer development or epidemiology. You can see sharply growing incidence and prevalence, development and positive trends in survival, but I must say significant disparities in diagnostics in our country, and regardless of improving diagnostics, still very high proportion of cancers diagnosed in advanced clinical stage. And these are the pictures, just an example, I have no time to go through it in details. These are exactly the pictures, exactly the reports that helped us to convince our stakeholders, policymakers, healthcare payers to change the rules of the game and to initiate completely new population-based screening program focused on organized prevention, organized early diagnostics of this cancer, just as an example. The second example, hospital level reporting, let's say, where we control each individual hospital stay and we are able to quantify, for example, penetration of services of some highly specialized centers in the population. Outcome measures, of course, self-benchmarking of centers, of hospitals, patient pathways among networks of centers. And all hospitals of this country, especially acute hospital care, are interconnected in just one reporting system, and they are able to benchmark themselves via the National Registry of Hospital Stays. This is the example again from the segment of cancer management and control, and you can see from the bar chart where the orange color means the accessibility of care in comprehensive cancer centers. This is really not a positive picture of our country. Again, the main important challenge is here heterogeneities in care, heterogeneities in access to care. And my colleague Mila Kulgar is writing new rapid recommendations how to minimize the heterogeneities, and we directly couple them with functional DRG systems, which is interlinked to reimbursement rules, and that's the way how via data we can push some rules and some evidence to slowly but continuously minimize the heterogeneities. And last example is focused on screening. My favorite screening, colorectal cancer screening, a very complicated population-based organized intervention, where you really need real-world data to control it, because this program keeps kilograms of evidence-based literature behind it. It's definitely proved that it has very significant efficiency, it's cost-effective or even cost-saving intervention, but if it is implemented correctly. And that's why we need to control more than 40 parameters, 40 dimensions to control the implementation. You can see, for example, compliance of population, coverage of target population, FOBT positivity rate, which is a tool how to optimize sensitivity and specificity of the screening. And as you can see, many things are good, but we've got still very weak points, very weak big challenges before us, because the compliance or coverage is up to 35% only. So again, the challenge how to convince not only policymakers but also population to attend the program. My time is over just now, and so now it's for the first in my life that I got it. I must end, and thank you very much for your kind attention.